So hi everyone, welcome to the Hepatitis C webinar. All participants joining the webinar today are in a listen and view only mode. After the presentation, there will be a question and answer session. You can submit a question at any time during the webinar. To do so, please type your question into the Q&A box located at the bottom center of your Zoom screen. You may need to move your cursor to tap it or touchscreen device to see it. This webinar is being recorded today and it will be available for viewing on the NUAA website in the coming days. NUAA proudly acknowledges the Gadigal people of the Eora Nation as the traditional custodians of the land on which our office stands. We extend this acknowledgement to all Aboriginal and Torres Strait Islander people across Australia and pay our respects to elders past, present and future. NUAA also proudly recognises people with living and lived experience of alcohol or other drug use, acknowledging their important role in shaping policy, education and services. We acknowledge that through their guidance, diverse experience and peer support, lives are saved and health outcomes are realised. We acknowledge that participation takes courage, gives a voice and reduces stigma and discrimination in our community. And with that, now I will hand over to Grace Crowley from Hepatitis New South Wales. Just on mute.
Of course, I was on mute. Hi, everyone. I'm Grace Crowley. I'm Program Manager for Community Support and Engagement here at Hepatitis New South Wales. Just going to get my window up and running and get the presentation up and running. Cool. So, yes, this is going to be the presentation I'll be giving, an overview around hepatitis C, treatment versus now and then, benefit and ease of cure now, side effects around cure, barriers to treatment and stigma. Firstly, I'd like to acknowledge country and community. I'd like to acknowledge the custodians of the many lands our team works and lives upon across New South Wales. We have peers from top to bottom and out west and in Sydney. And I'd like to pay my respects to elders past and present. I'd also like to recognise that Aboriginal people are still disproportionately affected by Hep C. I'd also like to pay tribute to our Hep C community, their resilience, their strength and their diversity. So just for those of you who might not be across Hep C, it's a virus that's transmitted through blood-to-blood contact only. So primarily the most common means of transmission is through sharing injecting equipment. Can also be transmitted through backyard or prison tattoos or piercing, anywhere where blood from one person may come into contact with another person, and that may only be the smallest of small specks of blood. Often you can't even see blood, and when I say sharing injecting equipment, that's not just the fit, but could be the spoon, could be the tourniquet, anywhere that blood can get on. It doesn't have to be seen to be passed on. If it can get in through an open cut and into someone else's bloodstream, it's a risk. So over time, if untreated, Hep C can cause liver damage and cirrhosis. In the worst case scenarios, can lead to death, but these days, fortunately, there is a cure. So at the moment, approximately 28,000 people are living with Hep C in New South Wales as of December, a couple of years ago. And that number's going down. Before 2016, the treatment was pegylated interferon with ribavirin. It was a long treatment and it often did not work, and it was a specialist only treatment, so people had to see hepatologists and go to liver clinics. Significant side effects, it was very similar to chemotherapy, nausea, vomiting, loss of appetite, and even hair loss. And it was really only suitable for use on certain genotypes. That's varieties of Hep C. You might hear people living with Hep C referring to genotype 1, 2, 3, etc. It wasn't always successful, even after that long, grueling treatment was often only successful in about 50% of cases. Many people chose not to start treatment unless their liver illness was quite advanced. And that was because treatment often outed people as living with hepatitis C. They often were not able to work, or they were not able to look after family because of the fatigue and the other side effects. Great news is that since 2016, we've had what they call direct acting antiviral treatments that actually stops the virus from reproducing, and the 97% cure rate, minimal side effects. Some people may have side effects, headaches, a bit of nausea initially, but in the majority of cases, very minor to none. Treatment, depending on which one the person takes, whether it's Epiclusa or Mavorite, is 8 or 12 weeks. And for the 3% of people who are not cured by those, there is a salvage treatment known as Vasevi, which is, as far as I know, 100% successful in all cases. If people get Hep C again, because getting Hep C and getting cured does not give you immunity to Hep C, that's why there is no vaccine for Hep C. People can get reinfected numerous times if they're engaged in activities that expose them to the risk of it, but they can get retreated. Also, the DAAs are pangenotypic. That means they treat all the genotypes of Hep C from 1 through to 6, and it's accessible in Australia to anyone with a Medicare card. It's very affordable. For people on a healthcare card, it's only around $10 to $12. And GPs and nurse practitioners can prescribe. So it's much more available within the community. People don't need to go to a liver clinic. The only time they may need to is if they have advanced liver disease. Fortunately, with the new treatments, the incidence of advanced liver disease is decreasing quite significantly in the community. So even with these great, fantastic treatments, there are still barriers to getting treated. Stigma, because Hep C is seen by and large within the community and even within clinical practices as a drug injecting related infection. There's a lot of stigma attached to it. There's a lot of discrimination for people from CALD backgrounds, but also Aboriginal Torres Strait Islander people. There's no culturally appropriate services, or very few, or they're difficult to access. There can often be an incomplete or unclear linkage to care. Testing these days is incredibly easy, and Nigel will talk later about dried blood spot testing that people can do in the home, but people still think that the old interferon treatment still exists, and they still think that they need to do full bloods and that kind of thing to get a test. So there's reluctance for people to test. They're not aware of the new treatment. Other issues such as poor mental health and other health issues can take precedence over what sometimes people treat as something they don't need to worry about in the moment. Sometimes people don't have enough health literacy to understand what needs to be done to get treatment. And of course, there's all the socio-economic aspects, such as lack of stable housing, lack of transport, especially in regional rural areas, and no support network. Just say a little bit about the work that Hepatitis New South Wales does. We have peers who have lived experience of Hep C and of cure, and we work in partnership with clinics across New South Wales. We have about 25 peer workers from Lismore to Albury, and many in Sydney and even in Wagga. They're trained and they're paid and they're experts in their lived experience, and they can meet people where the healthcare is. So we often go out with nurses in vans to help engage with community and test, and that's to reduce the barriers, reduce stigma in OTP, NSP, homelessness, community health settings, pharmacies, mental health, rehabs, public housing complexes, and so forth. So the work that we do is about meeting people where they're at with the healthcare that they need, getting them tested for Hep C, and then from that point on, hopefully they then, if they get a positive result, can go on to treatment and cure. So I'll just briefly mention that there's various testing options: dried blood spot, point of care, and also venipuncture. That still does happen, but Nigel will talk about dried blood spot testing. And incentives are often a way to help get people to come in and have tests, sometimes $20 gift card, sometimes it's work around any fines that they might have in the criminal justice system, and nurses and some LHDs help to reduce those fines for them. Here's one of our teams, peer workers, working with hepatology nurses, working with phlebotomists, and also someone from the HIV, hepatitis and related program support. Thank you. That's our team. Myself and JD work on the peer partnership program, and Kyle is working on point of care testing in the community. And that is me. I'll stop sharing my screen.
Thank you so much, Grace. I'll now pass over to Nigel Carrington from New South Wales Health.
All right, and I might just share my screen if that's possible. Here we go. Okay, well, thanks everybody. We can get this working. Yep. All righty. So yes, I'll just wanted to cover briefly what DBS is, why it's useful, what some of the data we have, how it's being used, and how we get access to it, and what it involves. So as people probably know, the state has these two important strategies, the New South Wales Health strategies, which are about trying to reduce or eliminate hepatitis C or HIV. In this case, we're talking about Hep C. And DBS is particularly about trying to increase access for the testing populations that might have barriers to testing, such as stigma and discrimination, lack of access to transport, or difficulty accessing confidential services, etc. So why is DBS or dried blood spot testing useful? Well, the good thing about it is that any trained person can perform a DBS test, so you don't need to be a clinician, a doctor or a nurse, and you don't need to have phlebotomy accreditation or anything like that. It's minimal and easy to use equipment. It's a finger prick test as opposed to a venous test. Doesn't need to be in a clinical environment, so it can be performed out in outreach settings in the community, in counselling rooms, for example. It doesn't have to be a clinical room. It's quick and easy to perform. The test results, negative results, can be delivered automatically by text, and positive results would always be delivered by a trained nurse. It's free to test and free results, and New South Wales Health covers the cost of the test kits themselves and also the pathology. And of course, we know that Hep C can be cured, and so we want to get people onto a treatment pathway as quickly as possible. Just some data I've got here, just for people to know. The study's been going for quite a long time now, 7 years or so, and up until March of 2024, in total, we've registered over 23,000 tests, and of those, over 22,000 people have completed a test, and we've found over 2,200 people living with an active Hep C infection that's untreated. So it's really important that we help get those people onto a treatment pathway. As you'll see there on the bottom left, we know also that in AOD settings, there's a greater rate of Hep C positivity as opposed to settings that are not alcohol and drug settings. The study has two kind of arms, basically. There's people who can test from home by going onto the DBS website and ordering a test kit themselves. And the other kind of big arm of the study is testing that happens through settings, such as the drug and alcohol services that you might be associated with, both government and non-government services. We have to date one Aboriginal community controlled health service, quite a few government drug and alcohol services, a lot of testing through prisons and the Justice Health Network, through NSPs, sexual health services and health promotion services. So as you can see there, the settings that testing with dried blood spot has already been occurring is in prisons, through community corrections, so those sort of parole services, in Aboriginal health, drug and alcohol services, mental health services, homelessness settings, through community organisations and NGOs, pharmacies, and in various outreach capacities. And as I've noted there, peer workers play a really important role and have continued to play a really important role, as Grace was talking about, across all of those settings. And certainly many of the services that are registered to offer DBS work in partnership with Hep New South Wales or NUAA to provide those peer workers. So I guess the important part is, well, how would alcohol and drug services in the NGO sector get access to dry blood spot testing? So it's important to understand that at the moment, DBS is only available in Australia, in New South Wales, not in any other states. And it's only available on this clinical trial that we're running, which is the DBS study. And that is because the DBS sample type and the assay is not yet approved by the TGA, so the Therapeutic Goods Administration. So because of that, the only way to get access to the DBS test kits is through this study. And the two options are either becoming an approved site, option 2 there, or option 1, which is to become to work with an existing registered site. So we have about 40 registered sites across New South Wales, in every local health district, and that includes NUAA and Hep New South Wales, who are also both registered sites. So what you could do is work in partnership with those sites to come in and do testing at your service. The other way, if you're a large service and have the capacity to become a registered site, is to do that, and I would work with you to complete the application form to get ethics approval. You'd need to get governance approval from your senior people within your organisation. nominate a principal investigator, and we would need to set up what's called your investigator site file, where it's important to have all of the right documents in place, as any clinical trial would have. You would then also set up a dedicated email address to receive the results, and there's some training that needs to happen. So there's some standard online training that everybody would have to do, as well as we would arrange some practical training demonstrating how to do the DBS tests, etc. So people might know, so just recently, actually, I've just come back from a trip up into northern New South Wales, and went to the Buttery, one of your members, you know, a really big rehab service offering a whole range of really terrific services to support people, and they expressed interest in becoming a registered site. So, you know, they've got a huge number of programs through which DBS could be offered, both in the drug and alcohol setting and in mental health setting. So it's a matter of, you know, me working with them to get all of those bits and pieces, the ethics approval, governance approval, and setting up all the documentation that would be required. I already do have, so obviously Buttery is one of the AOD hubs that has received funding through the federal government, and so we have actually already started working with some of the other AOD hubs around the state. Mission Australia, for example, at Common Ground, they've become a registered site, and also I'm working with Freeman House up in northern New South Wales in the Armidale Tamworth area, who are another big organisation who are interested to become a registered site. So that's what we're hoping to work towards, so that people then on the ground, all those caseworkers, can be offering Hep C testing in the settings that they're in. So what I've got here is just to show you what the DBS test kit looks like. You can see here the actual test card, which is just sitting here below the gloves, and that's the card that the blood gets dropped onto, as you can see in the bottom left-hand corner there. Got some Lancets, the alcohol wipes, so that's what we use to prick the finger and get the blood flowing. Once the card's dried, minimum of 4 hours, it gets put in this silver envelope, and then that silver envelope gets popped into the self-addressed envelope and sent off to the lab. You can see here on the left as well that there, because it's a clinical trial, there's a little survey that has to happen. This is only a 2-page thing. It's very quick and easy. That happens with each client as well, where we get, and that helps us gather the data, and that data from that form is entered into a special DBS website which allows us to collect the data, and also then facilitates the results getting back to the site. This is the form here. I'm not sure how clear that is for everybody, but basically you can see it's very, very quick and easy to collect details. We're just getting people the name and contact details, people, some demographic information, and what their eligibility is, and getting their verbal consent, sending that off. That data is entered into this special DBS website, which is not available to the public. So you would have to be provided that information from us and accessed by us. And then the data is entered into the website according to the form in the same questions that are listed there. So in terms of the future, what we're hoping to do is get this approved by the TGA. We're actually hoping that submission can go in before the end of this year, which would be pretty exciting if that could happen, at least getting us approval for the Hep C test, so that it could then be adopted into clinical practice without needing to fill out that DBS survey. It's, as Grace has mentioned, it's just one of the testing options that is available, and there's you know, another really important one that's happening at the moment, which is the point of care, which you can see on the bottom left there with that machine. And there's a new new things coming down the pipeline, like this Insti test, which again is not approved, but could become another really valuable test out in the community. All right, that's me. I will stop sharing, and I'm happy to answer any questions as well.
Thanks so much, Nigel. Yeah, we'll do a Q&A at the end. So if anyone's got questions, please just pop them into the Q&A box. I'll hand over to Nikkas Skelley now from NUAA.
Hi, I'm Nikkas. I'm here to talk about the peer perspective and point of care testing here that we do at our NUAA NSP. We've also been doing dry blood spot testing, which I'll also touch on about as well from the peers. So at the NUAA NSP on Crown Street, we have our own open clinic on Crown, which is open 4 days per week. And we host the open clinic with a nurse from Kirkton Road Clinic, Eliza. Our clinic is a peer-led clinic. So we actually have a Hep C engagement worker, peer worker that works with us here on the team and works very closely with clinic and the nurse. So we Tony does point of care, and gosh, that's just been a huge change. I mean, even dry blood spot testing has been a huge change for people to be tested with Hep C. We have the Gene Expert machine, which Nigel showed you a photo of just previously there. So, you know, a consumer would come in and have a chat with us at the counter, whether they're here to collect supplies, injecting equipment, or coming in just to have a bit of a yarn. And we'll get speaking with them and asking them how long ago it was that they were tested for Hep C. And that kind of really opens the conversation up by just instantly asking that question. We recommend people getting tested every 6 months. So that's really our lead into be able to get people into test for Hep C. So great thing is we have options. So there's a dried blood spot, as Nigel's just gone through, and also our point of care. The point of care testing is takes an hour, which is really quite incredible in comparison to having to wait a few weeks for results, or with venipuncture and with dry blood spot. There is a questionnaire to go through as well when chatting with the consumer who's chosen to do Hep C testing. We go through the questionnaire, and then depending on how people are responding to their questions. So if people have been on treatment previously or been exposed to the Hep C virus and aware of that, they would then just go directly into the, we would take a blood sample, which is very similar to the dried blood spot. It's just a finger prick, and take a sample of blood just from the finger, and that goes into the machine if people have previously had Hep C. Within an hour, those results will come back from that machine to inform us of like genotypes and of their Hep C results. If people haven't had Hep C before or been exposed to the virus, if they even need to have their blood go into the machine, we will do the instant testing, which Nigel just showed previously, that picture as well. So the instant test is literally just a finger prick sample as well of blood, and just goes into what's very similar to like the COVID testing kit. You know, we're all pretty familiar with the COVID testing kit. And within 15 minutes, we'll certainly know the results then if people are showing a positive result or a negative result to Hep C. If it is a positive result to Hep C, then they go straight through to the Gene Expert machine. And as I said, within an hour, they'll have those results. By having our open clinic on Crown, it's literally, that's our treatment pathway. So if somebody's returned a positive result, then we can just lead them straight through into the next door and get to speak with Eliza, our nurse. So we have that set up as our pathway. And then the nurse will chat with the consumer on their treatment options and how they want to proceed with their treatment options. They'll also need to have a fibre scan as well, and they'll also have a what's known as a rapid test for HIV and Hep B as well, because that will then determine the treatment pathway. That comes in with nurse. Tony's also Tony's the peer that does all of our testing with point of care and dried blood spot. So it's totally peer driven. And that works really well because we've built such a great rapport with our community that's coming into the needle and syringe program. So they have a really good level of trust with us, and want to actually know their results with their Hep C. Once the consumer has decided that they want to go on treatment, then we work, the nurse, Tony, and the consumer work that all out together. We support the consumer all the way through their treatment pathway, and we link them. We're linked with a pharmacy as well, so we will actually take care of organising their medication, linking in with the pharmacy. Tony will go down to the pharmacy with the consumer if the consumer wants to go to the pharmacy, or so it's really driven by the consumer on how they want their treatment from the start through to finish. We can collect their medication. We provide our consumers options on how they want to access their medications as well. So some people could be rough sleeping and homeless, so they might feel that they don't necessarily want to carry a whole lot of medication around with them. So they could very well come in and pick up their medications from us daily. They could pick them up and take away a week's worth. It's really up to the consumer on how they want to receive their medication. We've also linked our consumers up with like their opioid treatment providers as well. So when they're going to get dosed, their medication is there, so they pick up their Hep C meds as they're getting dosed as well. So it's really consumer driven. And with all the support of Tony, our Hep C worker, he will like check in and provide phone calls and check in with the consumer to see how they're going, and if there's what kind of support they require, or just to kind of have a chat with them. Was listening to Grace previously, and so there's still a bit of debunking around the treatments for hepatitis C as well. Some people are still, as I saw Grace say, that not so aware of the DAAs that are available, and still track back to the interferon ribavirin days. But once we kind of get through that and explain to them what the success rate is, and that has such minimal side effects to this medication, that's a really big bonus. So there's a lot of debunking of the myths and everything that still occurs around treatment. I'm going to just give a brief case study on a consumer that we had that tested positive for Hep C. They tested positive with Hep C through dried blood spot testing. They were a person who injects drugs, and their vein access was very, well, they didn't really want to have bloods taken through a venipuncture. So through DBS, yes, they tested positive. And then once we had the point of care machine set up, then he was able to come back in, and we tested him all through point of care, and he managed to go on treatment. So there was the barrier around the venipuncture access and taking bloods from the vein. That was a bit of a barrier to going on treatment to begin with, until point of care actually, till we had that available here in the NSP. this person also went through a lot of internalized stigma of being diagnosed with Hep C. They had a lot of discrimination from doctors and around in the past around being a drug user, being of same sex relations. They were also facing homelessness at this point of time, and they'd broken up with their partner in domestic violence. So there was quite a lot that was going on for this person, and they were definitely keen on wanting to cure their Hep C and get rid of it. They were certainly concerned about paying for medications because at that stage he was unemployed, and the cost of medications was also becoming a barrier for this consumer. We managed to deal with all of that by having great relationships with pharmacies, and so we were able to cover the costs for their medication and go on to that and support them around their relationship breakup and the homelessness, and providing all referrals to services required for those needs. They went on to treatment and had a really successful they treated really successfully, and by going on treatment, everything else then fell into place with this person. So they ended up finding housing, they ended up finding full-time employment, which they were so thrilled about. Their life came together and they're currently doing really well. Tony also gave weekly check-in calls with this person as well around whatever other support they required. And this person would also pop into the NSP to see Tony face-to-face and have a conversation. So, it's a real testament and power to peers being able to do this testing and being able to support people from our community. I've been working in peer-based drug user organisations for over 25 years. And, I've seen more and more peers being employed with in the AOD settings, which is absolutely brilliant. And so having the value of peers being able to work with the community is that they know the community. We know the community being peers. We can build rapport quickly. We can debunk myths and everything as well, because we've built that rapport up with our consumers, so they're trusted. So I would think if anybody's thinking about employing peers or opening peers up into services, that it's certainly something to look at. They having living with Hep C, and working with our consumers that are also living with Hep C, having gone through Hep C treatment yourself, means that you can certainly build that rapport and share those experiences that one's had, to really encourage people that if they're being still a bit more resistant or barriers around accessing treatment, it alleviates that. Because they're hearing it from somebody who's been living it and lived with it. NUAA also has an outreach team, and they got out into the community, regional and remote areas, and do a lot of testing. So they hook up with services in other local health districts and work with other local health districts in getting people tested. So they've done this via dried blood spot testing and also point of care testing. The peers will go out and do a lot of community engagement and connecting with the community in those areas for people to get tested. So there's could be big blitz days of testing over a couple of days periods in these out of the city areas. We had we had Peers on Wheels, which was a van that went out to regional remote areas last year, and within what was it, 6 months, they completed 500 point of care tests out there in the number of communities. So 500 people were tested through the point of care machine, which was just absolutely brilliant. And then what positive results would have been come back, they would have linked with treatment and care in those towns, and linked with and that's the benefit of working with local health districts as well, linking in with the local health districts, and supporting them with the community, with the results from the testing. There's currently being Hep Awareness Week. There's number of events that are occurring around in the city at the moment, and we've got a community engagement team from Outreach out there working with the LHDs in the Sydney area, and getting people tested as well, and speaking to them about testing and their Hep C status, and working very closely with LHDs. It's really beneficial having peers. I mean, of course, I'd say that having been one myself, but still to this day, we hear people, consumers saying that, you know, they want to be speaking with somebody from the community versus the book, you know, study person. However, I think, you know, there's a role to play. There's definitely, you know, it's a really good linked role together, but for the peers to be working with consumers, and then them building that rapport and trust, and then them seeing them working with like social workers and everything as well, that encourages our community to have that bit more of a trust out there. Having a moment here. So sorry.
That's all right, Nikkas. Thank you so much.
I would actually like to just also, if people are thinking about employing peers or have peers in their service and everything as well, NUAA has a number of, there's a group called Connected. We have a training program, and one is called Build, which actually starts today, and it's a 4-week course, and where people from the community can sign up and join Build, and it's a introductory course providing purposeful and supported training to develop the skills and knowledge of workers who have lived or living experience of alcohol and other drug use and or treatment, and building the individual capacity and confidence for starting your journey as a peer worker. Across the 4 sessions, people will be introduced to the fundamental knowledge and skills required to elevate their lived experience as a peer worker. The course is suited to students with no prior qualification or work experience, or to those that have had limited on-the-job experience and would like to consolidate it through the formal learning. The course has been developed and delivered by experienced peers. So some of the learning outcomes with the Build training is that they will develop confidence in understanding of best practice, including the principal values and practices of peer work, share part of their story in a purposeful and meaningful way, and discuss issues and challenges related to disclosure when drawing upon their lived experience with clients and colleagues. They reflect upon self-care and explore how to look after yourself to keep well. They'll understand and have the practical skills to undertake brief interventions, explore how to negotiate boundaries, utilize a range of communication skills, and practice listening deeply and holding the space for others. Developing co-design and co-facilitation skills, and appreciate the importance of collaboration and partnerships as pathways to better outcomes. So anyone who's with lived or living experience of drug use or alcohol and wanting to develop their skills or start peer work or is a peer worker can join these, can join the Build and register for it. The cost of that is free, and it is 4-hour sessions on every Tuesday over a 4-week period. And that's all done online. There's also Share. Share's designed to empower people with lived experience of drug use to share their stories in safe and supported ways, focusing on purposeful, meaningful, and substantial storytelling. In participating in this course, participants are supported to share compelling stories safely and effectively, make informed decisions about what they want to share, and deliver stories in engaging ways in work and advocacy settings. Focusing on practices of safe storytelling, this course incorporates specific guidance on how to manage legal and professional risks associated with disclosing drug-related behaviours. So you'll learn how to construct personal narratives, develop meaningful storytelling practices, understand how to work with an audience to give presentations, and effectively use lived experience of work and advocacy settings, and also recognizing the boundaries and risks of disclosure in various contexts. Anyone with lived or living experience of drug use and wanting to develop safe storytelling skills can register for the Share training. The cost of that's free as well. And that's a 3-hour session every Tuesday for 4 weeks. All of this is on our website. There's also
Thank you so much, Nikkas. Can I just direct everyone
Yeah.
to the newer website for the Connected program and all of that stuff, because I just want to get to the Q&A if that's all right.
Yeah, fantastic.
Thank you so much, Nikkas. So just a reminder, you could submit a question by typing your question into the Q&A box located at the bottom center of your Zoom screen. You may need to move your cursor or tap your touchscreen device to see it. We've got a question in the chat. So this is open to anyone that would like to answer it. Could you talk about how people in regional and rural areas access treatment? What are their options? I'm concerned that people might test and then not follow through the treatment. Anyone want to? Grace? Can't hear you, Grace.
Sorry, I must have popped my microphone up. Sorry, yeah, that can be quite an issue for people in regional and rural areas, getting transport, but also finding treatment that isn't going to stigmatise them. Getting a dried blood spot test is a really fantastic way for a person to self-test and at least then find out what their status is. Once they get contacted by the service that Nigel runs, the nurse that speaks to that person, if their test is positive, can talk them through the next steps. Also, Hepatitis New South Wales runs on our website a directory that's statewide, or New South Wales wide. Sorry about other people from other states, but we have a list of services that can and will treat people living with Hep C, and they've indicated, well, and we also get feedback about whether or not this service is stigma-free. Sometimes we get feedback that that's changed when we update the directory. The cascade of care is a very significant issue. There can be quite a drop-off between a person getting a positive result and then them getting into treatment. With DBS, often they also still have to have confirmatory bloods to make sure, yes, that is the case. They do have Hep C, and that can also be a point where people are lost to follow-up because people are homeless or have changeable housing arrangements and lose phones and so on. Can be hard to keep in touch with people even after they have started on treatment. People might go off treatment. Hepatitis New South Wales also provides a service called Hep Connect. It is an app-based, it's a free app-based program that allows people to keep track of their treatment. So reminders to take their medicine either once every day or a couple of times every day, depending on which one they're taking. Reminders to get their scripts renewed with the pharmacy ahead of time, reminders of any appointments with GPs or healthcare. So there are a number of ways, but there is still many gaps in the cascade of care, and even more so for people living in regional areas. And for Aboriginal people, it can be particularly difficult. They don't necessarily like to seek out healthcare with the local AMS. We've been doing research around that recently, and feedback is some people don't mind going to their AMS, but some people will not go there because they're worried about people talking about them and being recognised in the community as living with Hep C. So sometimes they'd prefer to be treated at the local town clinic rather than go to their AMS. So it's a case of trying to tailor the treatment to the needs of the person and not trying to make it fit the other way around.
Thank you, Grace.
I could maybe add to that as well, Jen, that you know, I think there are a lot of specialist Hep C nurses out in those regional areas, and so you know, we certainly would you know, if they're tested through a site, those sites will do their best to kind of link people into those specialist nurses who can sometimes go out and visit people, or, you know, try, as Grace has mentioned, there is quite a bit of flexibility out there. We also have remote prescribers who we can get involved to do prescribing if there's not a doctor available that's suitable. And certainly, you know, in many rural areas, we've gotten a lot of people onto Hep C treatment. So I think it's really a matter of kind of working with the contacts that we have and linking people into those sort of support services. But there's certainly options available.
Yeah, thank you, Nigel. Another question, the next question that's come through is, do people have to have stopped using completely or stopped drinking to go on treatment?
Not at all.
No,
No.
not at all. No. And there's a poster in the background where Nikkas is that says you can get clear on gear. So it is possible for people to continue to use. It's not required.
Perfect, thank you. Another question is, if I work in a small organisation, can I as a worker train to do DBS testing? How do we go about following that up?
Yeah, look, I think if you're working in a small organization, the best thing to do would be to work in partnership with an existing site and sort of just get in touch with me, and I can find out, you know, where you are and what might be the closest site. And then it's a matter of working with that site about whether they could have you train up and be auspiced under their site, or whether, you know, we would get them to kind of come and work with you to offer blitz testing or something like that. So just depends on the detail, I guess, about where you are and what might be close. So feel free to send me an email.
Yeah, perfect. We'll share contact details. The kind of speaks a little bit to what you're talking about before, Grace, but what can we do as workers to support people to stay engaged in treatment? Even though the treatments are better, I reckon people might drop out. Any thoughts?
People do tend to drop out. It's a case of understanding where they are. Sometimes other life issues can be overwhelming and take precedence. If people do drop out, that's unfortunate. It can be possible to restart them again, but trying to find the support that they need for those competing issues, whether it's proper housing support or other health-related support, and reminding them too that getting cured of Hep C may not seem like a huge thing, and sometimes it is and sometimes it isn't for people, but it is one less thing to have on your plate. It's one less thing to have to juggle, to worry about, and a lot of people, when they've been living with Hep C for a long time, don't realise the effects that it's having on them. Whilst there can be obvious acute symptoms when a person is initially has the virus, such as nausea and various other kind of jaundiced type symptoms, those go away within a few months. But as the virus stays in the body, people often find that they lose energy, they lose focus, things become quite foggy. And it becomes difficult to deal with all the other stuff that's going on in life. So many people have reported with the direct-acting antivirals, because of the quick process of it, that they start to feel better within the first few weeks. That's not everybody's experience. It's not a cure-all for other general life malaise, but people often find they have more energy, they've got greater focus, and that energy and focus allows them to start dealing with other issues in their life. Start to be able to, okay, maybe now I'll sort of figure out what I can do about this or that. So that having Hep C off people's shoulders can be quite a game changer, a life changer for them. We had one peer who said he was kind of jealous that he didn't get that result immediately, but he was also living with quite deep depression. But it also then, being free of Hep C, gave him the opportunity to start working on those, and now he's dealt a lot with his mental health and feels great. So it just is an opportunity to remind people that there are benefits and find support for them in other areas that can help them achieve those goals. But certainly getting cured of Hep C can make a huge difference in people's lives, and it's important to remind them of that.
I'd probably add to that as well, just that, the important role that peer workers can have. Oftentimes the peer workers from NUAA and from Hep New South Wales have been able to help people navigate, that care pathway and can be a support around how to do that, as well as just the experience of having been on Hep C treatments, etc. So there's the support that peer workers can provide, as well as engaging with some of the Hep C nurses that we have out in regional and remote areas are really amazing, and so they're a support themselves. And Grace, did you want to speak about your app?
I've put a link in there for Hep Connect in the chat, and as I mentioned before, it gives people reminders about taking their pills every day or twice a time during the day, depending on which treatment they're on. But it also reminds them to get go-to appointments and so forth. It does provide vouchers and incentives for people to keep going through to the end. It is free. It is New South Wales only, I'm sorry, but we had 50 people sign up to it this last financial year, and the program's been growing quite a bit. It's just a great way for people to keep in touch with their healthcare. Yeah.
Definitely. Thank you so much, Grace. So it's right on time. So again, thank you to Grace, Nigel and Nikkas. And thank you all for attending today. There will be a short evaluation survey emailed to you, and we would really appreciate your feedback on this webinar. Also, please visit nada.org.au to sign up for the advocate, to view the recording of this webinar as well. And thank you all very much.
Thank you.